Dear students, Assalamu alaikum. In the last lecture, we were studying the renal tubular disorders. The objectives of today's lecture are to learn about rest of the tubular disorders, mechanism of dialysis, artificial kidney. Gitelman syndrome. It is an autosomal recessive disorder of the thiazide sensitive sodium chloride co-transporter in the distal tubules. The features of Gitelman's syndrome are salt and water loss, activation of the renin-angiotensin aldosterone system. However, these abnormalities are less severe as compared to Barter's syndrome. The next syndrome is the Liddle's syndrome. Liddle's syndrome is a rare autosomal dominant disorder. Its cause is mutations in the amiloride sensitive epithelial sodium channel in the distal and collecting tubules. Its features include excessive activity of epithelial sodium channel, resulting in increased reabsorption of sodium and water, hypertension, and metabolic acidosis. These patients have decreased aldosterone levels. This is because of sodium retention and compensatory decrease in renin secretion and angiotensin II levels. We now move on to the treatment of renal failure. Severe loss of kidney function, either acute or chronic, is a serious condition and requires removal of toxic waste products, restoration of body fluid volume and composition toward normal. This can be done by kidney transplantation or by dialysis with an artificial kidney. There are two main mechanisms based on the principle of dialysis. Number one is the peritoneal dialysis, and number two is the hemodialysis. Let's first study peritoneal dialysis. The process in peritoneal dialysis uses the patient's peritoneum in the abdomen as a membrane across which fluids and dissolved substances are exchanged from the blood. Fluid is introduced through a permanent tube in the abdomen and flushed out every night while the patient sleeps. This type of peritoneal dialysis is called automatic peritoneal dialysis. The other variation is that the fluid is introduced through the permanent tube in the abdomen and flushed out by regular exchanges throughout the day. And this type of peritoneal dialysis is called continuous ambulatory peritoneal dialysis. Have a look at this figure. The figure shows the mechanism of peritoneal dialysis. The fluid is being introduced through a tube in the abdominal cavity, and the patient's peritoneum acts as a membrane across which fluids and dissolved substances are exchanged from the blood. The other type of dialysis is hemodialysis, which is more safer than the peritoneal dialysis. The basic principle is to pass blood through minute blood channels bounded by a thin membrane. On the other side of the membrane is a dialyzing fluid into which unwanted substances in the blood pass by diffusion. The blood continually flows between two thin membranes of cellophane, and outside the membrane is the dialyzing fluid. The cellophane is porous enough to allow the constituents of the plasma, except the plasma proteins, to diffuse in both directions. That is, from plasma into the dialyzing fluid and from dialyzing fluid back into the plasma. if the concentration of a substance is greater in the plasma than in the dialyzing fluid, there will be a net transfer of the substance from the plasma into the dialyzing fluid because of diffusion. This diagram shows the principle of hemodialysis. Blood is passed through minute blood channels of a membrane. On the other side of the membrane is the dialyzing fluid called dialysate, into which unwanted substances in the blood pass by diffusion. This figure shows the components of a type of artificial kidney in which blood flows continually between two thin membranes of cellophane, and outside the membrane is the dialyzing fluid. The cellophane is porous enough to allow the constituents of the plasma, except the plasma proteins, to diffuse in both directions, as pointed out earlier, that is from plasma into the dialyzing fluid or from the dialyzing fluid back into the plasma. Now, if the concentration of the substance is greater in the plasma of the patient than in the dialyzing fluid, what will happen? That there will be a net transfer of the substance from the plasma of the patient into the dialyzing fluid. The rate of movement of solutes across the dialyzing membrane depends upon these factors. Number one, the concentration gradient of the solute, the permeability of the membrane, the surface area of the membrane, and the length of time, that is, for how much time the blood and fluid remain in contact with the membrane. The maximum rate of solute transfer occurs initially when the concentration gradient is greatest, that is, when the dialysis is begun. However, it slows down as the concentration gradient is dissipated. Now let's study the mechanism of the artificial kidney. In normal operation of the artificial kidney, the blood flows continually or intermittently back into the vein of the patient. The figure shows the wrist of a patient, and you can see the connections are made between the dialysis machine and the vein of the patient, from dialysis machine to the vein and from the vein to the dialysis machine. You can also see an AV fistula in the wrist. The total amount of blood in artificial kidney at any given time is less than 500 ml. But the rate of flow may be several hundred milliliters per minute. And the total diffusion surface area is between 0.6 and 2.5 square meters. To prevent coagulation of the blood in the artificial kidney, a small amount of heparin is infused into the blood as it enters the artificial kidney. In addition to diffusion of solutes, mass transfer of solutes and water can be produced by applying a hydrostatic pressure. Such filtration is called bulk flow. Now let's study about the dialyzing fluid. Water is mixed with dialysate concentrate to form the dialysate, and water used is highly purified before use. The concentrations of ions and other substances in the dialyzing fluid are not the same as the concentrations in normal plasma or in uremic plasma. They are adjusted to levels that are needed to cause appropriate movement of water and solutes through the membrane during dialysis. This table compares the constituents in a dialyzing fluid with those in normal plasma and uremic plasma. Note that there is no phosphate, urea, urate, sulfate or creatinine in the dialyzing fluid. I repeat again, there is no phosphate, urea, urate, sulfate or creatinine in the dialyzing fluid. So when these are present in the high concentrations in the uremic blood, they can easily diffuse across the dialyzing membrane into the dialyzing fluid. Therefore, when the uremic patient is dialyzed, these substances are lost in large quantities into the dialyzing fluid by diffusion. Effectiveness of the artificial kidney. The effectiveness of the artificial kidney can be expressed in terms of the amount of plasma that is cleared of different substances each minute. Most artificial kidneys can clear urea from the plasma at a rate of 100 to 225 milliliters per minute. This shows that the artificial kidney can function about twice as rapidly as two normal kidneys, both of the two normal kidneys together, whose urea clearance is only 70 milliliters per minute. But artificial kidneys have got their own disadvantages. The artificial kidney can only be used for only 4 to 6 hours per day and 3 times a week. Therefore, the overall plasma clearance is still considerably limited. It's also important to keep in mind that the artificial kidney cannot replace some other functions of the kidneys, such as secretion of erythropoietin. With this, I end today's lecture.